I don't have a op follow-up on this one, but again, like probably an interesting case for discussion. Again, a young 28-year-old female who has history of endometriosis, chronic pelvic pain. And I'll move on to PACS images on these. I really need to scroll the images and show you the case. So she has history of endometriosis. She has been operated in the past at an outside hospital, and it was the op note that created a little bit of confusion here. So these are the sagittal T2 images. You can see the uterus, the endometrial cavity, and there's this focal abnormality here in the fundal area. This is the only coronal that I have. And this is where she was operated, so susceptibility from surgical clips. This is endometriotic deposits, residual endometriomas, and the left head necks are T1 hyperintense. And as we can see, this focal abnormality in the uterus has internal T1 hyperintensity. So the confusion in this case came from the op note, which says that they had operated a right horn, uterine horn, a remnant horn, and that's where the surgical clips are from. So I already see the answer here. Arina said it correct, like this is adenomyoma. So more specific name to this would be cystic adenomyoma. I'll move on to my presentation here. So the differentials, then we thought, because there was a history of, so she has known endometriosis, and there was history of surgery where they were saying that they had resected a remnant uterine horn on the right side. This was the op note on this patient, where they said that excision of right aspect of uterus and right uterine horn with debulking of endometriosis. So based on that, the differential that we were considering is cystic adenomyoma. The other differentials that hold good for this kind of an appearance is an accessory cavitated uterine mass, which is known as ACUM, or an obstructed rudimentary horn. Like the debate was whether this is a manifestation of adenomyosis, or this is a Mullerian duct abnormality where there is a rudimentary horn. So again, I think we went through the literature, and based on OB literature, they say that there is a diagnostic criteria for this ACUM, accessory cavitated uterine mass, that there has to be no evidence of pelvic endometriosis. And we know that endometriosis and adenomyosis coexist. So if there is an evidence of endometriosis or adenomyosis in the pelvis, and if you have such an appearance in the uterus, then it's probably not a Mullerian duct abnormality. You should favor more of a manifestation of adenomyosis or endometriosis. So diagnosis here probably cystic adenomyoma. As I said, I don't have an op follow-up, but there's enough convincing evidence on imaging that that's probably what it is. So just a quick recap for what adenomyosis is. It's invasion of the endometrium into the myometrium with hyperplasia of the adjacent smooth muscles. You classically get thickening of the junctional zone. We get these T2 bright foci, which correspond to the ectopic endometrial tissue within the myometrium. But it gets confusing to make a diagnosis of adenomyosis when it presents with its atypical pattern, which can be a focal adenomyoma, adenomyomatous polyp. That's an example from the literature. Sometimes adenomyoma can be like a polypoid growth projecting from the cervix, or cystic adenomyosis, as probably in this case. And often if you have adenomyosis in pregnancy, it can undergo destructural changes and can cause or can mimic a pelvic mass. So what is cystic adenomyosis? It's basically like the histopath criteria is when you have a cyst that is filled with hemorrhagic fluid, and it's lined by endometrium and surrounded by myometrium. So it's actually a miniature uterus within a uterus. And if you see the histopath of those Mullerian duct abnormalities, same thing. These are also cavities which have an endometrial lining surrounded by myometrium. So both on imaging and histopath, there is no real difference between all the conditions that we listed in the differential diagnosis. The important thing is, if there is evidence of endometriosis and background adenomyosis, we should favor more of cystic adenomyosis. So what is accessory cavitated uterine mass is a variety of Mullerian anomaly, generally located at the insertion of the round ligament. And this is the diagnostic criteria from OB-GYN literature, that it's a mass that's in the location of the round ligament, and you should have normal uterus, endometrial cavity, fallopian tubes, and ovaries, whereas in this case we know that there was enough evidence of endometriosis within the pelvis. So hence that like the surgeon's question was, do you think it's a Mullerian abnormality that they've operated her for, or it's just all manifestation of endometriosis or adenomyosis? So I think we can confidently say that it's all probably related to adenomyosis and probably was not a Mullerian duct abnormality. So that's one of the reference journal articles from Obstetrics and Gynecology Journal, which talks about the diagnostic criteria in this condition.
Cool, I've never heard of that. Dr. Asher says, why isn't this deep invasive endometriosis into the uterine serosa mimicking adenomyosis? So I guess she was thinking in this case, why wasn't it basically endometriosis from the outside invading the uterus?
Yeah, but we know that endometriosis and adenomyosis can coexist, and with such an appearance where you have localized thickening, which almost looks like there is like another endometrial cavity here. So this is the normal endometrial cavity of the uterus, and there was another cystic space which almost looked like a second endometrial cavity. And these are all like classic imaging findings described for cystic adenomyoma, and she had known adenomyosis. So if we go back to the op note, they had said that they had debulked the surrounding adenomyosis where they had done surgery. So just based on that, it's probably focal adenomyosis.
ACUM. Cool.